just want to start with the human side of myself, right? Because that's what brings us to this table. I never thought I would do nutrition. I'm a pediatrician and an internist, med peds. I have at least one med peds friend here. We're a little bit weird, like we're people who decide to train to care for patients across the lifespan. And then I became an academic primary care physician. And towards the early part of my residency, my husband really began to be sick all the time. And I won't go through his symptoms. He'll thank me for that. But basically, he ended up getting diagnosed with celiac disease. And this was roughly 12 years ago, before it was easier to be celiac than it was then. And that's when I got embarrassed that I had no idea what to do for us. And then later, one of my children ended up also getting diagnosed with celiac disease. And then around the same time, my mom got breast cancer and was told, hey, what you eat influences your risk for recurrence. And so I want to just remind everyone how deeply personal this is, and that many patients, physicians, other healthcare professionals are not willing to dive into all that this can be until it hits right here. And so look for it to hit right here and see those as opportunities when your patient walks in and says, my brother just had a heart attack and now I'm really concerned about my risk. And so that's the entry point for many people, is when it hits personally. And so, yes, I've been doing culinary medicine. I got certified in culinary medicine through CCMS, and I also have lifestyle medicine boarding. But for me, that was I can't practice the way I was trained, because it did not prepare me for everything that I needed to do to help my patients or even my own family. So our short time together, we're going to try to do these things. The first one is what I call the life cycle of culinary medicine. At least has been my journey and many people I've spoken with. How do you go from the initial, hey, let's educate everyone, to, oh gosh, someone has to pay for this? And then examining how the business world, I have no business expertise, but I began to search business literature for mentorship in how do I frame the narrative around what I'm trying to do so that it meets the need that my institution or other people in my community have. And then thirdly, I'm going to tell you what we did, which is actually super low resource. I hope many of you can take it home and start next week. And that's, how do you deliver electronic consultation in culinary medicine? And then how do we scale this? How can that be a launch pad? And that's going to set up for Dr. Christy Art's sharing of her amazing work in shared medical visits. I have no disclosures. Sometimes I wish I did. But yeah, my disclosures are that I'm a mom and a human, and I'm just figuring this out along with the rest of you. So here's my life cycle of culinary medicine. So I feel like most of us start at the top or in the community section. Okay, so we're going to say education. Who can we educate? We can educate students of all different flavors. We can educate our GME trainees. We can educate other health professionals. We educate our family. And we believe that when you do that good work, someone's going to notice it and fund it. And I'm still waiting for that 7 years into this, so I'm just being honest. It's really difficult because education ultimately doesn't have a measurable return on investment for institutions. They can't say this is what we're going to make off of what you're doing. And then the community work, that's the heartbeat. That's the passion for so many of us. Also really difficult to find sustainable funding. And so for about 5 years, I lived in the fairyland that I'm going to do what I believe in and it's going to work out. And then I started to recognize, you know what? This gains momentum and it gains support when I lean into the funding sources that are sustainable. Research, you could argue, maybe isn't a sustainable funding source because it's project-based, it's grant-based. But when you think about clinical integration, the potential is potentially, I'm overusing the word potential, it's endless. It's endless because there's always going to be a person, an individual or a group or a community that wants care that's culinary medicine based. They're asking for it. And if they aren't asking for it, that's just because they haven't heard the semantics yet. But when you start giving the language to your community that this is a way to get medical care that changes the foundation of your health, people come. So I want to go back to education for a minute because I don't want to belittle the importance of this. It's a natural start because if you're at an institution where there's learners or you have a community that wants to learn, they're a captive audience. So you can integrate it somewhere. You can find a place to start. It fills a gap. We know the literature is robust, that we are not educating the way that we need to be around the foundation of nutrition and health. And many of you may be familiar with McGovern and Burgess's recent resolution in the House that said, we have to make this required. And I actually think there's great work that's happening through, I mentioned Harvard's health policy center that's at the law school, health policy clinic, I think is what they call it. And they have been trying to say, let's get this on the exams, because guess what? If it's on the USMLEs, suddenly the medical schools are going to be like, oh, we have to put that somewhere. And so there's going to be some incentives that drive education. Enthusiasm of learners, Tim always refers to the learners as the force multiplier. They're the ones who get it going. They're the ones who wake you up. You know, I was thinking to myself as the music was playing, like if my students were here, they'd all be like in the corner dancing. They bring energy to everything because they have so much hope. They don't have the jadedness that some of us are trying to work through and figure out how to reapply our energy. And then the legacy benefit, which I mentioned, is not always measurable, but they're carrying what you put into them with them into the next season of their lives and practice. And I hope they're forever changed. So how do we have a broader vision for what this can do? So yes, education is both an initial and a sustainable investment that is hard to deal with. That doesn't mean it doesn't matter and we shouldn't continue to do it, because it powers the other endeavors. Research. I'm an academic. I have to keep doing research. You know, it's how we show that what we're doing has an impact. We can't just say we think it does, even though, like, you know, believe in culinary medicine, you're sure it's working, but you need to show how it works. How do we measure it? But clinical integration suddenly expands this to everyone who's training in this now knows what to do with it. And that's what Tim alluded to, that we are training people. And then how do they actually make this work? Yeah, we can talk about it one-on-one at cocktail parties and with our patients in the exam room, but how do we more practically and directly apply culinary medicine? And then I believe this sets the stage for all the innovation that needs to happen in the way we deliver care in this country. So I always like to say, you start with your goals. And many of us don't sit down and have that little creative brainstorm. Like Millette and I like to go to coffee shops and sit there for 3 hours and back and forth. And we say, okay, what about this? Well, what about that? And what about this? And coming to conferences is how you get ideas and you feel inspired. And I would encourage you on the plane ride home, write down some goals that are very specific and also very bold. Then recognize that it might not work out like that, and that you have to walk through the open door. And sometimes the open door is not the one that you thought was going to be first. It's not even the one that you liked the most. And that can be hard to swallow. But that then opens other doors. And another thing that's really important is I also used to think that the Venn diagram of my vision and mission and that of my institutions didn't have to overlap. That was really naive, right? So sometimes I don't think they always care about the things that I care about, or they think that it can be achieved in the same way. But then I realized if I can align my mission and vision with some of theirs, suddenly you've got a little more progress. But it takes some intentional thought to get there. So I'm going to give you just like 5 quick tips that I learned from business world. And then how do we apply this to culinary medicine? And then we'll talk specifically about e-consults. So the first one is building your brand. What does that even mean? That means that you stand for something and you have found a way to articulate it that people find resonating. They say, oh, I kind of like that. I want to do that, or I believe in that. And your brand can evolve. You know, you can be about one thing and then you shift a little bit or you broaden a little bit, but don't be too broad. I would say start more narrow and then build it out, because you want to be really good at what you do before you broaden. Elevator pitch. Everyone knows what that is, right? That's your 30. I was joking with Sabrina yesterday. She was like, okay, well, how long is the elevator? You know, how many floors do we have to tell you the story? I am long-winded. I'm sorry. But I'll still stay within my time today. But most C-suite people, they have the attention span of a flea, you know? So it's like, you've got to give them 2 sentences and they're done with you. And so I know that it's hard to narrow in what we believe in, but try to say who you are and what you're going to do with it. And then practical, low-hanging fruit. Yet another thing that when we're in our busy, just constant attending to putting out fires, we don't sit down and notice those things. You have to be intentional about stepping back and saying, what's already going on that I can just be part of and elevate? Like, don't reinvent the wheel every time. And we'll come back to that. Partnering up. So I think the most rewarding, and perhaps the reason I have not burned out in this, is finding people in other spaces who are similarly looking for partners. So Millette highlighted some of our public health colleagues yesterday. They wanted to do more integration in the clinical space, but they're PhDs. So I went to them and said, hey, can we study this together? I don't actually know what I'm doing and writing grants. Can you help me? And then we started getting funding together. And now it's expanded across different departments. Go to departments that aren't your own. I love all the OB and ER people here. Can I get a hand wave from my OB-GYNs and my ER people? They're front lines. The OBs are literally setting the stage for the health of a child for their whole lifespan. And we do not emphasize enough how important that time frame is. And then in the ER, they see everyone. They're the only people who can't say no to you. And so you show up there, I mean, they have to tend to all of it. And so there's such potential to go outside of our normal departments and sectors. And then the last one here, finding lanes already paved, is about going down the highway that already is there. And you might use a different vehicle or a different part of the highway. But if you have to start from scratch, it's a lot more work. So you might not have chosen that road, but look for the roads that are already there. So just some super quick examples of each of these. So building your brand. I'm not going to tell you how long it took for me to get my institution to make a web page, but I will tell you that education wasn't enough. They said, you come back to us when you have a clinical offering that patients want to see on the website. And so when I suddenly had that ability, they were like, oh yeah, we'll make you a web page. So think about what it is that they want on the website. Do they want educational materials only? If not, if they want it to be a clinical entry point, that may be what you have to wait for. And then I just put at the bottom right, Millette and I laugh about we asked for like a mark. We can't really do a logo, but we wanted an affiliated mark. And it took a while for us to get that too. And, when I emailed at church, she was like, oh, I see how that took so long. Like they literally had to write the gray font across the bottom. But getting your institution to say, we want our name on that takes a while too. I mean, years for us. And so you're not doing it wrong if it's going really slowly. So I think just take that to heart. This is a slow and uphill battle for many of us. And just back to the concept of an elevator pitch, ask yourself right now, can you in 2 sentences say who you are, what you do, and this is key, how can you fix a problem that they have? So one of my examples is my institution is a big accountable care organization. And I know that they've kind of run out of ways to save money in some of the Medicare population. And so guess what? Culinary medicine might be an awesome pilot to see if a certain subset of the population, say those with diabetes, could get more benefit in cost savings. So those are the places you have to look for. How can you solve a problem that they have? Being practical. This is my email signature. Like all of us have one of these. It's where I started to say, you know what, I'm going to put in there that I'm a certified culinary medicine specialist. And guess what? Random people who have nothing to do with this will say, what's that? What do you do with that? And how do you begin to put what you have done in this space into words that just might catch someone's eye? And then they reach out to you. And that's how you build connections. So low-hanging fruit. So Millette and I, in our not so fancy 1975 teaching kitchen that is part of our dietetics program, we started saying, who else can we give classes to besides students? Who are those people? You're looking at the associate dean of the medical school and 2 of the top PR and development officials at our institution. I invited them to class. And guess what? They're all friends with us now. They think about things that they can support culinary medicine. Now, have they found me millions of dollars yet? No, but we're working on that. But the point is, find the people who have influence and who will benefit your program by knowing about it. They had a great time. It's a team building activity to do a culinary medicine class. And this could be virtual if you don't have a teaching kitchen, okay? And then partnering up with people that are strategic. And so on the left, you see one article that one of our colleagues worked with a team across North Texas and published life expectancy by zip code. And it was staggering and disturbing. And I thought this is a great way for us to partner on how do we improve the health of a community that has clearly been marginalized in intentional ways historically in our area. How do we lift them up with food? How can we collaborate? And then the same thing with another colleague who recently did a study on food insecurity in North Texas, looking at qualitative experiences. And you heard about a lot of those voices yesterday. So how can you intersect with work that is similar? And then I mentioned lanes already paved, and now I want to turn this to e-consults. So who before today knew what an e-consult was? That it's a thing. This is a CMS benefit, and I'm going to define it for you in a second. But lanes are already paved in other specialties. Why can't they apply to culinary medicine? We are a specialty. And then lastly, how did I even get this idea? This is my clinic team, and they know that, sometimes when we're frustrated, we all sit around and brainstorm, like, how are we going to get ourselves out of this annoying situation? And one day I was sitting there actually complaining that I get emails from colleagues across our campus with nutrition questions. Why? Because there's inadequate access to RDs, mostly because these questions are things that wouldn't get reimbursed by the current payer models in Texas. And then people will text me, well, what about this? What about that? And we all get tired of giving free advice, especially to people that you don't actually do life with. And so someone else said, hey, Jaclyn, why don't you make an e-consult? And I was like, can I just do that? Can I just make that up? So that's what we did. Okay, so what is an e-consult? It is asynchronous, which means it happens on your own time, whenever, wherever. And it's a provider to provider, a clinician to clinician communication within the EHR or other web-based platform. And so the research in this that's emerging has begun to show a couple of key outcome measures. One is that it improves access to specialty expertise, especially in areas where that's limited. It doesn't require a face-to-face visit. And I'm not saying this replaces the face-to-face encounters that absolutely need to happen in the culinary medicine realm, but this is an entry point. It's flexible and fast. And I'm excited about this because I have 2 continuity residents that are going to spend a half day a week with me every 5 weeks for the next year. And we're going to train them in how to do this. And we're going to give them the experience, because when you don't have a lot of time to do things, that's when you can really bring in students, residents, and other trainees to make the magic happen. Okay, so we're just going to look at a couple of successful programs. This is in New York. So New York Health and Hospital System, when they started e-consults, they found that they could actually resolve 13% of specialty referrals without ever seeing a patient. So they were able to then have higher success of getting the people in that did need to come in person, and then reducing wait times. Because you all know how it is when you're trying to get somebody in with nephrology and it's 6 months and you're like, I hope their kidneys don't die between now and then. And it's so overwhelming as a primary care physician or an ER physician or someone else in an urgent care setting when you can't get access. So this improves access. And then particularly in a safety net system, it takes away some of that strain. So this slide shows another group within the VA, and they did e-consults. And what you see in the red there, those were actually pre-op. So it was orthopedic surgery looking at in advance who actually needs to be pre-oped or not. And they were able to eliminate a lot of unnecessary pre-op appointments. And then you see cardiology is the heaviest hitter, hematology, sleep, anesthesia, GI, pulmonary, ID, endocrine, even ophthalmology, determining, do we need optometry or ophthalmology? How do we make sure people get to the right space? So why can't culinary medicine fit in here? I liked the phrase used in that same VA paper of disruptive innovation. And I want to put it out there, and I've said this to a couple of you in person this weekend. Institutions like innovation, they're not so sure they like disruptive innovation. All right. So it's a messy process when you say, we're going to shake up what we're doing and do it differently. But when you do something like e-consults, you start to see the benefits. There's better communication. Communication's a huge problem between different people in the health system. Even what Tim was alluding to when he was introducing the afternoon, that Millette and I didn't even know what the other person was doing, and we didn't even know who we were. And there's so much of that happening. It aligns with the virtual pivot that all of us have adapted to in the era of post-pandemic life. And I'm sure we're kind of just waiting for the next thing. And having virtual skills is going to be key. And then team-based care. So why can't we work in teams of physicians and dietitians and chefs more intentionally and more often? And I just want to say, as a physician, dietitians have been so marginalized and undervalued by health systems in the payer model. It is our job to elevate their work as we get engaged in this space, and to partner with them and to bring them along with us in the payer model, and to say, why aren't we reimbursing both of us? And I really hold that as a responsibility, because sometimes physicians have a little more leverage in advocating for reimbursement models. So please own that and work with a dietitian. And so there's my partner in crime. We like to call ourselves culinary medicine besties, but I really say that, you know, the nutrition expertise that they have, and then the billing structures and leverage that we have as physicians in a system can partner together and be such a win-win. And I hope, you know, to report back in a year or two to you about some of the things we're going to be trying next, but we've got to prove that the partnership delivers better care. And I believe that to be true wholeheartedly. So take a moment to digest this good news. E-consults, when CMS does something, everyone else follows. You know, all the private insurances cover this as well. 99451, it's an electronic, kind of like a telephone code, but you don't actually have to talk to the patient or anyone. It's fully electronic. It's only 0.7 RVUs, but imagine if you start to do a lot of these and they take 5 minutes, right? Or what if I do 2 of them on Saturday afternoon? And that accumulation of doing them here and there and everywhere, I drop a clinic session, changes your life a little bit. So you start to think about how you could fit this in. So what does this look like? It's a win-win for both. Requesting clinician can also bill. So that's them getting credit for saying, I saw this patient, I thought about what their needs were. They do have to document that the patient consented to the e-consult. Most patients get a copay of $5 to $10 or less. I've never had a patient complain about their copay on this. And then the billing code you see up here for the person requesting the consult, they bill when they communicate back to the patient. So they can send a MyChart to the patient and then bill with my recommendations as the consultant. So the consultant rules are, you can't do this more than once a week for the same person, which makes sense. And then you can't bring them in person to your specialty within 2 weeks. And then you do have to document this in an electronic way. And then you see the billing details. So for a minute here, we all love the teaching kitchen model, and I do that, but I don't have a patient teaching kitchen, not yet. And I don't know if I will or when I will. And this requires no resources except for culinary medicine training and interprofessional partnership. So you don't need a kitchen. You can do it anywhere, anytime. You get paid for it. And it just perpetuates the model that we believe in of team-based structure. So let's go a little more granular. So I just will say I have no attachments to Epic, but that is the EMR that my institution uses. Love-hate relationship, right? But you can see how at my institution, if you type in e-consult, we've got a bunch of options. I actually had to send them an email and be like, why is culinary medicine at the end of the list? It should be alphabetized. And so they fixed it. It's now up there at the top, a little easier to find. But then when the clinician who's consulting us opens, this is what they see. And I just made this up. There's probably room to improve. So you know, and you guys have these slides for those taking screenshots. So it just basically, has the patient been consented that there were out-of-pocket costs, and the responsibilities on the person consulting who sends me the consult. And then I give them a one-liner. My clinical question related to the role of food in my patient's health promotion is, and then there's some optional checkboxes here. And then they can link it to diagnosis. So what diagnosis codes? Well, you guys know, throw them out there. Diabetes, hypertension, hyperlipidemia, CAD, obesity. Now, I have never billed solely on obesity because I find that insurance payers are a little sketchy about reimbursement for obesity as the primary diagnosis code, but there's always something else. So you can always throw something else in, and I make that the primary code. What's one we talked about? I don't know if my prune friends are here. Osteoporosis. That's a wonderful one for talking about nutrition. What else? Celiac. That's near and dear to my heart. Reflux. Yeah, it goes on and on. Mike, I've even had ones that say, I was on antibiotics for a dermatologic condition and I need to know how to recover my microbiome. I mean, that was one of the more creative ones we got. So all of these codes go in there. And then when it comes to me, it's in my in basket. This was a really beautiful day. Notice no MyChart messages, unresolved, no calls. Okay, so this is a rare moment in my life, and I don't want to know what it looks like right now. But basically, it tells me who's the doc who sent it to me, and then who's the patient, which I've obviously blocked out here for you. But that's what an e-consult in basket looks like. And then my response looks like this, where I have this little box. So I hate these little tiny boxes that try to force you to type. So I do this all in a Word document, and I just copy and paste it, and I'll show you why in a second. And then it shows up as a note in the chart. I bill, click my little box. And then this is how we sign things. And this goes back to the partnership. So I'm the one billing for the service here, and my name is the one that shows up in the chart. But it needs to be stated that this is a team effort. So whatever team you have, you sign it that way. And we work on the content together. But I need to bear more of the work because I'm the one who's billing for it. So think about how you structure that with your team. And I love that it's in the chart like any other encounter. So it's like the patient had a visit with me, and that generates more curiosity. That's the brand building. Anyone who's skimming through that chart, oh, what's a culinary medicine e-consult? So let's give you some examples. And I just picked some of our recent ones. So a woman who had good general health, normal BMI, and she had elevated ASCVD risk, but she did not want to take a statin. So she just wanted to know, what can I do with my diet to reduce risk? So that was an easy one. How many times are we going to get that same consult? Oh, now it's only going to take me 2 minutes because I'm going to copy and paste what I did for that person with a little bit of individualized content. Okay. Then the next one's similar, but a younger patient who had their first child and thought, oh, I want to think about how I reduce cardiovascular risk because I'm in a new season of life. And so the advice that I give him is going to be a little different than someone else. And I also know that he's a vegetarian. I mean, the cholesterol comes up so much, actually. People are really interested in how diet can improve cholesterol. So this gentleman was actually underweight. And the consult was, how can we improve cholesterol without promoting weight gain? And then the last one here, it was the one I mentioned a minute ago, that she was treated with antibiotics, wants to know how diet can impact her rosacea as well as her gut microbiome health. And she was also suffering from constipation. So that was getting a little more complex. We're bringing in 3 different things that we can overlap advice on. So what do we put in the e-consult? I put a one-liner. What's the patient context? Mrs. Smith is a however old patient with this problem. And if I was giving any insight on aspects of their personal or social life or dietary pattern, then I put that in there too. And then I put a very brief narrative summary of what we recommend, including key references. I consider 1 and 2 for the consulting clinician. 3 through 5, copy and paste material that can go straight to a MyChart for the patient. Here are the general points that we recommend. We want you to eat more of this, more of this, more of that. That's another way that we can start to change the narrative of stop this and that and everything else to how do we tell people what we want them to be eating. And guess what? Here's 4 recipes that come from really great sources that you might find other recipes again later. We're just trying to get them to go to this website, try this out, and then hopefully make a pattern. And then local resources. I've had some consults that are related to food insecurity. How do we send people to the right resources in the community? So my institution, again, uses OneDrive. I'm not promoting this in any way, but I created this database now. So I've got these folders that have different handouts and other resources. And then each consult that we do, I have a Word document by topic. And next time I do that consult, I can take probably 75% of the content I've already written. So it gets easier and easier. And then you can share this. Millette and I pass documents back and forth and articles back and forth that we keep in the database. So let me give you an example. So consulting physician, I think I mentioned this one. So the patient wanted help with a chronically underweight patient. And I'm sitting there going, oh, this patient's never been screened for celiac. No one's looked for vitamin D deficiency. No one's looked for iron deficiency. And you might actually be able to offer some insight that's nutritionally related to the medical management. And I throw that out very casually because that's not the main point of my consult, but it can be really rewarding. And I got so much gratitude back from this physician in particular for helping think of some of those things. And then for the patient, let's just talk that this is hard and you're not doing it wrong. Like this is hard. And sometimes validating that in writing can mean a lot to a patient. And then the same stuff that I've already mentioned, you throw in the real life recipes. So here's just a couple of quotes. These are things that physicians have said, and I'll let you just glance at those. And we're getting continual feedback that, hey, you know what? I might even know what to say, but the patient wants to hear it from a specialist. Right? So we're getting some credibility to our specialty when we say the specialist in culinary medicine. And yesterday or the day before, when I was on my way here, I got a consult from an endocrinologist and I was like, oh, a specialist has consulted the primary care doctor. What is happening in the world? Disruptive innovation at its finest. And then I read in the fine print, culinary medicine consulted per patient request. And so then my heart sank a little bit, but then I still thought, oh my goodness, this patient who I've never heard of asked for my input. And so how do we begin to build that this is a resource and an entry point? Okay, in our last few minutes, I'm going to just tell you this is actually up to about 35 consults. All of them have been reimbursed by insurance. And the e-consult team at my institution said no other specialty has gotten 100% reimbursement. So they're paying for it. It's not a lot, guys. It's not a lot, but they're paying for it. And so this is a way to build a foundation of culinary medicine as a clinical service line. So when we start to gain momentum and inspire that curiosity, which is all the things, it's the brand building, it's the website, it's the mark, it's putting your signature information about culinary medicine, you get people who come to you because they're now in the culinary medicine fan club. Like Millette and I did a demo for something on campus last week. And, one person was like, I'm just in the culinary medicine fan club. And so I'm just here to learn. And if you ever need to hire anyone, can you please hire me? And people start to want to be part of this because they need the way that we're doing everything to change. The way that medicine is delivered is depressing right now. And I will stand here and say, I've been a primary care doctor for 9 years, and I don't have much left in me in the way that we do it in this country. And so to me, culinary medicine and lifestyle medicine are the new primary care. And I'm going to try to form a pathway where we can train the next generation of primary care to be dedicated to prevention and providing people the resources they need to be successful in that. I know y'all are with me. Y'all are with me, but it's much harder to have these conversations with people who don't get it. And they don't see that this is a long game, not return on investment in 6 months. So we've got to start finding ways to frame our productivity, our goals, and our outcomes so that we get the support that we need. And then this in no way substitutes for the one-to-one RD consultations that are needed. And something that Millette and I are going to be trying soon is we're going to start a culinary medicine consult line that's one-to-one. And if she cannot bill MNT codes, I will see the patient briefly first and pass them off to her, and we'll bill as a team because we're doing a pilot model at a new satellite site. Those types of innovations where physicians and dietitians work together and figure out when it makes sense for the physician to bill and to work together. That's how we get through this. That's how we find ways to make this sustainable. So I want to end with a couple of thoughts. One is that don't be sad if it's slow, because growth is difficult to manage. And you have to, sometimes it takes 2 years to get out of a commitment that you're in when you realize you need to shift some of your time or energy somewhere else. And I made a decision a couple of years ago about 2 things I was going to retire from on our campus, and I just finished them. So it takes a while before you can start to allow growth in one space to shift your time or energy. And we have to work hard at not getting burned out, because this is a passion project. I told someone last night, in full transparency, the only protected time I have for culinary medicine is research grant funding that I got for myself in partnership with someone else. None of my educational work is funded or protected. And I'm hoping that the clinical work can become a foundation of my clinical delivery, and that protects itself. That's the beauty of it. You don't have to go looking for a grant. E-consults are an educational tool for the clinician and the patient, and a billing strategy. And the more we put culinary medicine knowledge out there, the better. Because the random people who look at the chart in other specialties, or nurses or students, they're going to maybe learn something. I always try to put the latest evidence base, a couple of articles that person who might have a spark of curiosity, they're going to go chase that article down. And then don't forget to bring all the team members with you. If you have access to chefs on your campus, that's amazing too. It's not something that we have yet, but Culinary Dietetics is the natural partner. And don't forget to do this through the open door. So taking you back to the beginning, set your goals, but stay flexible and adaptable. Be willing to pivot. It's kind of like parenthood, right? This is how we think the day is going to go, but then everyone has to get another snack or whatever it is, and we go through a different pathway, and that's okay. All right. So we're ending here because I was on a call with Dr. Arts about a month ago, and we were just talking about our 2 talks. And I was just sharing with her how much her work means to me and how inspiring it is to apply shared medical appointments in culinary medicine, and that's our next step. And then she was sharing her own vulnerabilities and challenges, and then I was sharing mine. And we just want to be really frank that this is the Hunger Games. And we might look like we got ideas and we're going to do this and we're excited and we're successful and we're making waves, but we still feel hunted. We still feel like we have to justify every move we make and it's not enough. And the difference between Katniss's situation and ours is that she was technically alone and we are not. And we have to remind ourselves that when we bring everyone to the table, we all partner together. We don't all agree on everything. We can stand here and argue about nutritional nuance, which I don't think has a ton of value when it comes to delivery of patient care. But we are all here because we care about doing this better, about bringing our patients to a place of wholeness and thriving that isn't surviving and barely getting by. We want that for ourselves and our loved ones. And we have to function as a team because it really is the Hunger Games. And then lastly, I think social media, which makes me nervous. And my students actually set up my Instagram account. So they're like, you have to just put food on there. It's fine, just do it. And so I do have that, and it's not very exciting. And I don't actually want to grow my following massively, but if you want to connect with me, please do. And that's just a picture of my kids planting this cool portable gardening kit by a company that's near us and has reached out to us several times, called Gardenuity. And they try to teach families and kids how you can grow even just on your porch or your backyard. And they have these cute little kits and you can order them online. Again, no financial association with this company, but it was an amazing experience for my kids. And we're still eating off of this little mini portable garden. And that is all I have for you. And I know you're going to love hearing from Dr. Arts, but just remember, we're in this together and there's room for everyone at the literal and proverbial table of culinary medicine.